Autism or Autism Spectrum Disorder, ASD, is a neurodevelopmental disorder that affects communication, behavior, and social interaction. Understanding autism involves exploring its neurological underpinnings, varied symptoms, and the importance of individualized approaches to support and provide inclusion. The next several slides will delve into the characteristics of autism and strategies for interventions. Symptoms in ASD include impairments in social interactions, emotional processing, repetitive behaviors, and restricted interest. Behaviors that are seen by 12 months are poor eye contact, no response to name, lack of sharing, gesturing, and loss of language. In preschoolers, behaviors are limited to pretend play and intense interest. School-age children usually show concrete thinking, lack of understanding emotions, and may be interested in peers, but they lack the social skills. ASD is more common in males than females. This may be because females don't receive a clinical diagnosis.
I know.
This is Nicholas. He's 6 months old. He's enjoying himself, but this is no ordinary playtime. A highly trained clinician observes him as they play. Nicholas is taking part in a study looking for early signs of autism. The study is conducted by Dr. Sarah Patterson, a research assistant professor at the University of Pennsylvania and Children's Hospital of Philadelphia.
The first thing they do is come in at 6 months, and they come in and do a number of different behavioral tasks with us. We look and see their baby strengths and weaknesses, how they're developing generally, their motor skills, their language skills, how they understand the world, how they react to people around them. And we also are interested in how they interact with others. So do they enjoy playing with strangers? Do they enjoy playing peekaboo? Those kinds of things.
Jason is another 6-month-old taking part in the study. Cameras in the room record each session. For the study, Dr. Patterson works with Dr. Robert Schultz, a professor at Penn and the director of the Center for Autism Research at CHOP.
At 12 months, the babies come in and do behavioural assessments with us too. And we're also looking for strengths and weaknesses, early signs of autism. IBIS stands for Infant Brain Imaging Study, and it's a longitudinal study of children who are at risk for autism because they have a brother or sister with autism, and we follow their development carefully between 6, 12 and 24 months to look at how their brain and cognition develops over time. And at 24 months, our visit's a bit more involved because at that time we can really have a look and see if the child meets diagnostic criteria for autism.
He's really playing on his own, so the clinician approaches him at this point to engage him in a toy, which he looks interested in. He doesn't really look at the clinician, then kind of goes back to doing his own thing.
Can I try it?
Sure.
For this study, we're using 24 months as our endpoint, and actually what we're doing to be really sure is we're bringing people back at 3 now to confirm that diagnosis.
Oh goodness! Phil! Done.
You're done?
Oops.
Do you think he's okay?
Yeah.
Okay.
In September 2012, the researchers were awarded an additional 5 years of funding from the NIH. This allows them to continue the study and to begin seeing infants as young as 3 months old.
I know.
Individuals with greater social communication deficits showed structural alterations in the amygdala connected network. Male showed to be affected in the subguinal anterior cingulate cortex at 38 months. Female showed alterations in the left superior temporal gyrus, and increased gray matter volumes were found in regions monosynaptically connected to the amygdala. Higher autistic traits showed hypoactivity in the left amygdala when doing tasks involving imitation or facial expressions, especially fearful ones. Amygdala and mirror neuron systems have increased functional connectivity. This suggests a compensatory neural mechanism. As the amygdala becomes less efficient, mirror neurons adapt to compensate for social and emotional processing deficits. Research has shown decreased gray matter volumes in the right crus of the posterior cerebellum, increased gray matter volume in areas associated with the default mode network, such as the superior frontal gyrus and anterior cingulate cortex, have also been found. Areas involved in sensory motor integration and processing had reduced gray matter volumes as well. Treatments aim to reduce symptoms that disrupt the quality of life. There's behavioral treatments. I will go into more depth on that on the next slide. Developmental treatment seeks to improve language skills, physical skills, speech skills. These are often combined with the behavioral approaches. The most common is speech and language therapy, which helps improve communication skills. Other common ones are occupational therapy. Occupational therapy helps the person live more independently. This includes sensory integration, which helps improve sensory input, and physical therapy helps improve physical skills such as fine motor skills and gross motor skills. Educational treatment is given in a classroom setting. One approach is the treatment and education of autistic and related communication handicapped children. This helps teachers adjust the classroom so they can improve academic outcomes. The social relational approach helps improve social skills and with building emotional bonds. This can involve parents and peer mentors or peer mentors. Developmental individual differences relationship-based model. This helps parents to focus on the individual's interests. Relationship developmental intervention also increases the motivation and interests and abilities to participate in social interactions. Cognitive behavioral therapy also helps cope with anxiety and depression that the individual may have. Applied behavioral analysis, ABA, is a scientific approach used to understand and change behavior, improve communication, social, and adaptive functioning. So this is a behavioral intervention. It modifies behavior by manipulating stimuli and using reinforcers. Techniques like discrete trial training are used to break tasks into small teachable units and repeated trials. Parent-mediated and paraprofessional-mediated models have shown positive improvements in adaptive communicative functioning. Developmentally informed interventions stresses emotional engagement and positive relationship between the child and the adult. Learning in naturalistic and socially meaningful environments, scaffolding during interactions are used in ABA.
Are we working for Elsa again or Fishy? Fishy. Okay, let's work for the fish. Cup. Yay, you got the cup. Do this. Good. Cup. That's the cup. You got it. You get working for Elsa again or fishy?
In summary, autism is a complex and diverse condition that emphasizes the need for tailored support. By understanding its unique characteristics and advocating for inclusion, we can create a more supportive environment for individuals on the spectrum. Continued education and research are vital for promoting acceptance and enhancing the quality of life for those with autism and their families.
Hey everyone, my name is Olivia Herrick, and to be adding to our group's discussion on brain disorders, I will specifically be talking about Parkinson's disease, specifically the causes, treatments, current research, symptoms, etc. So Parkinson's disease is a neurodegenerative disorder that affects predominantly the dopamine-producing neurons in a specific area of the brain called the substantia nigra. Looking at the overview of Parkinson's disease, some of the symptoms may include tremors, maybe slowness of movement, limb stiffness, balance problems, etc., which these are all movement-related symptoms or motor symptoms. Parkinson's also includes non-motor or unrelated to movement symptoms as well, which can be depression, anxiety, apathy, hallucinations, etc. So it really affects both sides of your body, which you can see there in the image below, some motor symptoms and some non-motor symptoms. The prevalence of Parkinson's disease, it actually is increasingly growing. Nearly 90,000 people are diagnosed with Parkinson's every year in the U.S., which is a 50% increase from the previous year. So it is something that is increasing as time goes on, and typically is found in people who are 85 and older, and maybe even 65 and older, but typically it is found in the older population. Looking at the cause and risk factors, unfortunately the cause is largely unknown. Scientists believe that it is a combination of genetic and environmental factors, but due to this, scientists and doctors really can't treat the actual root of the problem, which then allows the disease to keep spreading, which is so heartbreaking. Some of the risk factors include past traumatic brain injuries, maybe head injuries from contact sports, toxin exposure such as pesticides, metals, etc. And as far as gender, males are 50% more likely to develop this than females. And the condition often appears with people from 60 years and beyond. And some drugs and medications can also be some risk factors as well. As far as the diagnosis and treatment, you can be diagnosed through a neurological exam, brain imaging, such as MRIs, medication, and then in the graph below, we can see that males are much higher percentage to have this disease rather than females. As far as the treatment goes, you can be on medication, go to physical therapy, speech therapy, and there's also this new surgery called deep brain stimulation, which basically is a surgical therapy that is used to treat certain parts of it. It does not fully cure it, but it does help relieve symptoms and stop some of those pains, but it does not cancel the progression of the disease. But it is very specific in what it does. It basically targets an area of the brain using an MRI, and looks at the brain activity, and implants an IPG under the collarbone or in the abdomen, and delivers an electrical stimulation in the targeted areas, which allows the brain to act as if it did not have the disease. As far as living with Parkinson's and future directions goes, there are some lifestyle adjustments, such as engaging in regular exercise, focusing on nutrition, and managing daily tasks with adaptive tools and strategies. As far as your mental health, people with this diagnosis may have to address depression and anxiety, maybe through counseling or medication, practice mindfulness, stay connected with friends and family. Although Parkinson's foundations provide great resources, and caregivers are also at your fingertips as well, which is great. As far as current research and further direction, there's gene therapy, stem cell research, neuroprotective drugs, biomarkers, technological advances, and clinical trials, which are all advancements into researching the disease and into trying to find a cure. In conclusion, Parkinson's disease is a challenging but manageable condition with early diagnosis and comprehensive care, improving the quality of life. Advancements in gene therapy, stem cell research, neuroprotective drugs, and biomarkers offer hope for slowing progression, and support for research and innovation is vital to finding a cure and enhancing treatment outcomes.
Creutzfeldt-Jakob disease can mimic other forms of dementia as it causes changes in mental abilities and problems with speech and thinking. According to the MayoClinic.com, CJD is a rare degenerative brain disorder belonging to a group of conditions known as prion diseases. Prion diseases are progressive, fatal, and untreatable degenerative brain disorders. They affect the nervous system, causing abnormal body movements, changes in memory, personality, and behavior. Prion diseases can be sporadic, familial, iatrogenic, and a variant CJD. Infectious protein particles that cause neurodegenerative diseases such as CJD was discovered by Stanley Prusner in 1982 when he isolated suspected infectious agent called prion. Creutzfeldt-Jakob disease symptoms get worse usually within several weeks to a few months. CJD causes rapid mental deterioration, leading to symptoms such as personality changes, memory loss, impaired thinking, blurry vision, or blindness, insomnia, problems with coordination, trouble speaking and swallowing, sudden jerky movements. There is no cure for CJD. Most individuals diagnosed with the disease usually die within a year due to medical conditions associated with the disease, which include falls, having heart disease, lung failure, or pneumonia, or other infections. Risk of getting CJD is low. Eating meat contaminated with bovine spongiform encephalopathy can increase risk. Sporadically spontaneous. People may develop the disease for no apparent reason. CJD or sporadic CJD accounts for most cases. Inheritance or familial. Fewer than 15% of people with CJD have a family history, can test positive for genetic changes associated with the disease. Occupational contamination is also possible, as occurred in France with the last two victims of variant CJD who died in 2019 and 2021. They were research technicians at the National Research Institute for Agriculture, Food and the Environment. Emily Germain, who died in 2019 at the age of 33, had been the victim of a work accident in 2010, during which she had pricked herself with a tool contaminated with infected brain. Diagnosis is based on symptoms and medical tests after other possible causes are ruled out. Having at least one living or deceased ancestor with the disease, in case of familial CJD, increases the chances of developing CJD. Treatment focuses on alleviating symptoms and providing supportive care. Pain can be relieved with methadone or morphine administration. Variant CJD gained public attention in the 1990s when it was linked to consuming beef for cattle infected with bovine spongiform encephalopathy, aka mad cow disease. Prion proteins typically produced in the body may encounter infectious prions, which cause folding into an abnormal shape, thus spreading and negatively affecting normal processes in the body, as shown to the right of the screen. Staging of cerebral cortical pathology. In stage 1, a spongiform change, as you see in the slide below. Stage 2, hypertrophic astrocytosis. Stage 3, neuropil rarefaction. Stage 4, neuron loss. Stage 5, status spongiosus. And stage 5, large cavity formation. First stage, the onset is more common in patients in their 50s and 60s. Patient initially presents with non-specific symptoms such as fatigue, unsteadiness, dizziness, decreased inactivity, anxiety, depression, visual disorder, and memory disturbance. The second stage, cognitive dysfunction worsens rapidly. Communication becomes difficult and muscles twitching appears. Gait disturbance progresses and difficulty in walking. Neurological examination shows various neuropsychiatric signs such as motor paralysis, aphasia, apraxia, sensory disturbance, brisk, deep tendon reflex, appearance of pathological reflex, and cerebellar ataxia. Third stage, disease progresses to the akinetic mutism state, and the patient subsequently presents with decorticate rigidity or tetraplegia inflection with contracture. The patient generally dies of infection, aspiration, pneumonia, respiratory failure, or general prostration. The life expectancy of those diagnosed with CJD is drastically shortened. About 70% of people diagnosed with CJD die within 6 to 12 months. Frequency of death is 1 to 2 people per million per year. Prevention can be achieved with gene editing of children of risk for familial CJD. In 2004, a report showed that the variant CJD can be transmitted by blood transfusions, although a blood test for CJD infection is possible. The test kit is not yet available for screening blood donations. Moreover, standard cleaning methods don't destroy prions that cause CJD. As a result, a small number of people have developed CJD after medical procedures, which included injections of pituitary human growth hormone from an infected source, cornea and skin transplant from people who had CJD, and after brain surgery with contaminated instruments. Finally, although sporadic CJD tends to develop later in life, usually around age 60, an onset of familial CJD occurs slightly earlier. Variant CJD is known to have affected people in their late 20s.
Epilepsy is a neurological disorder that affects 30 million adults and children worldwide and is the fourth most common neurological disease in the United States, affecting 3 million people. Epilepsy is characterized by abnormal brain activity that results in seizures. This disorder has a wide range of possible causes and seizure symptoms, which requires a treatment approach that is unique to each individual. There is not a cure for epilepsy, but this disorder can be managed in most cases. Epilepsy is related to an electrical storm occurring in the brain and is considered a disorder of electrical potentials. Brain activity is usually desynchronized in that neurons send electrical impulses at different times in different regions independent of each other. The main symptom of the epilepsies are seizures. A seizure occurs when brain activity all of a sudden becomes synchronized, in which electrical signals are all transmitted simultaneously over stretches of the brain in waves, known as the spike and wave pattern, which destabilizes the brain and body. Seizures can be neurologically, physiologically, and psychologically devastating. The cause of half of epilepsy cases are unknown. Some of the determined causes of epilepsy include fetal injury, brain injury, abnormal brain development, and genetics. Epilepsy seizures can be categorized as either generalized or focal. Generalized onset seizures include tonic-clonic, absence, tonic, myoclonic, clonic, or atonic. There are two types of focal seizures, aware or impaired awareness. 60% of patients have focal onset seizures, which are commonly found in temporal and frontal lobe epilepsies. The main difference between focal and generalized is that generalized seizures involve a loss of consciousness. Other seizure symptoms include, but are not limited to, muscle stiffness, uncontrollable movements and auras, and seizures can be triggered by a lack of sleep, hormonal changes, and by not taking medications regularly. The first line of treatment for epilepsies are anti-seizure medications. The specific ASM prescribed is dependent on the type of epilepsy, type of seizure, and other health factors. ASMs do not cure epilepsy, but control seizures in about 70% of patients. ASMs work by blocking sodium, chloride, potassium, or calcium ion channels on the postsynaptic membrane, preventing neurons from transmitting electrical signals to other neurons. Some ASMs work by preventing ions from entering the ion channels in the presynaptic neuron, which decreases neurotransmitter release. Both mechanisms result in brain stabilization, and this can be seen in the two short videos. About 30% of patients have seizures that are drug resistant. Resective surgery is an invasive surgery that requires sections of the skull to be removed to expose the brain in order to surgically remove the seizure onset zone. Temporal lobectomy is the most common and is 70 to 80% effective in controlling seizures. Frontal lobectomy is the second most common, but it's not as effective. In severe cases of epilepsy, a corpus callosotomy is performed to sever the corpus callosum to prevent nerves on the left and right side of the brain from communicating. Current research on epilepsy promotes medial temporal laser interstitial thermal therapy as the first choice in surgery, as it is not as invasive, removes less than a centimeter of the skull, and the seizure zone ablation is laser guided. Neuromodulation is a surgical option for epilepsy patients who do not respond to anti-seizure medications or who are not candidates for resection surgery. There are three types of neuromodulation: vagus nerve stimulation, deep brain stimulation, and responsive neurostimulation. The vagus nerve helps control involuntary sensory and motor functions and is involved in the parasympathetic nervous system. A generator is placed in the chest and a lead wire is attached to the vagus nerve. When stimulated, electrical impulses are sent to the left vagus nerve, then through the brainstem to the brain to counteract abnormal brain activity. Dries and colleagues recently studied if a microburst VNS was feasible and safe in mediating seizure activity. They found that electrical bursts given at a high frequency, greater than or equal to 250 Hz, may be more effective than the standard low-frequency VNS, noting that on average 70.4% of participants had a reduction in seizure activity. Responsive neurostimulation and deep brain stimulation are both types of intracranial neuromodulators that involve placing a stimulator and electrodes on or deep within the brain. RNS and DBS do not cure epilepsy, but reduce the frequency and severity of seizures. In RNS, a stimulator is placed in the skull and leads connect to electrodes that are placed at predetermined focal seizure sites on the brain based on EEG readings and other tests. The stimulator constantly monitors brain activity, and at the onset of a seizure, the stimulator sends electrical impulses to the focal seizure zone to prevent a seizure or stop it from becoming a generalized one. Bedetti and colleagues suggest that RNS modulates and disrupts epileptic seizure networks as opposed to disrupting seizure events, further noting studies that point to epilepsy as a network disorder. DBS is similar to RNS, however, key differences are that DBS does not respond to the onset of seizure activity, but provides a preset cycle of electrical stimulus to the brain. In addition, DBS targets the anterior nucleus of the thalamus or the centromedian nucleus deep within the brain, whereas RNS targets a particular focal seizure zone with electrodes placed on top of the brain. Bahadori and colleagues suggest that DBS works to desynchronize the thalamocortical and cortical activities through the thalamus's role in the Papez circuit when related to the temporal and frontal lobes. Watch these two informative videos to see how the RNS and DBS neuromodulator systems work. Ketogenic diet therapies are another treatment option for epilepsy patients. These diets vary in their ratios of fats, carbohydrates, and proteins. He and colleagues found that the classic ketogenic diet resulted in a 64% withdrawal rate of at least one anti-seizure medication for study participants. Mutarelli and colleagues noted that the modified Atkins diet was as effective as the classic ketogenic, is less restrictive, and has fewer side effects. Medium chain triglyceride and low glycemic index treatments are other available ketogenic diets. Mishra and colleagues relay that the mechanisms behind ketogenic diets are that ketones aid in the reduction in excitatory glutamate and enhance inhibitory GABA, enhance the function of mitochondria, and modulate gut microbiomes and sleep patterns. Epilepsy is a complex disorder that has neurological, physiological, and psychological effects. I would like to close out this section by asking you to join Jen and I as we discuss what it is like to live daily with epilepsy, from her tonic-clonic seizures to her frontal lobe resection surgery that required a craniotomy, and most importantly, the role that her faith in Jesus has in helping her and her family navigate this disorder.
Good afternoon, class. I'm here today with Jen. Jen is a friend of mine that I've known for about 8 years. She has epilepsy, and I've invited her today, and she's been gracious enough to share with us a little bit about her condition. So I'm just going to ask her some questions. She's got some responses for us, and we'll go from there. So, Jen, if you could tell me how and when were you diagnosed with epilepsy?
So I was diagnosed with epilepsy at the age of 26. Actually, it was 11 months into marriage, and December 2nd, 2006, almost 19 years ago.
And what type of seizures do you have? And if you could help us just understand, like, what happens with your body physically, what happens emotionally?
So when I have a grand mal seizure, my whole body will shake and then go stiff. My whole body feels like I was in a train wreck. I don't remember it because I go unconscious. So this is all coming from my husband telling me what I was doing during that time. I feel bruised and beat up, and usually I have to be in bed for 2 days to try to heal. My migraines then will start to come on, and usually that proceeds with the grand mal seizure and then afterwards. So I also deal with migraines as well.
I'm sure that's pretty scary when that
Oh, and
happens
emotionally,
as
I feel
well.
really down too, because just feeling just like the clock is starting over again. You feel like, oh, I made it a couple weeks, and then bam, another grand mal seizure. So it feels like my hope is kind of crushed during those times.
How often would you say you have grand mal seizures?
At least once a month, but it could vary up to 3. So yeah, it's mine. They can't really understand why they came on. It was kind of out of the blue. So
Okay, interesting. Now, I know that you've had brain surgery.
Yes.
Could you tell us a little bit about that? How long ago was that? What sections did they work on, or what the hope was?
Yes, absolutely. So I had brain surgery. It would have been 2 years after I got diagnosed with epilepsy. And since they noticed a lot of my shaking and my stiffness came from my left side, they automatically thought, let's look into the right side, because the brain is always opposite. So I ended up having a right frontal craniotomy. And it was in hopes to obviously remove the tissue that was affecting the seizure activity as it was coming on. So they actually took out, like, probably I would say a size of like a cutie orange. And, this center does affect language and speech and things. So they were very careful not to remove too much of the tissue, because that could involve extensive therapy, learning how to walk, talk again. So they got as close as they could to the margins where it was, and it worked for 2 months, and then they all came back again.
Oh.
So that was very disheartening, because I spent a month in the hospital. They had to open up my skull, and first of all, I had to shave my hair, and that was hard because I always had very long hair. But anyway, that was the worst. That was the least of my problems. They shaved off all my hair. They put in electrodes on my brain when they opened up the scalp, and just to make sure it was coming from the right frontal lobe, they took me off cold turkey, off all my seizure drugs, and then they just let me have some really good seizures to identify the exact area that the seizures were coming from, and it did show that it was the right frontal lobe. And so that's what the resection was for in the surgery.
Interesting. I wonder what brought it back. Like, I wonder what.
No idea. They can't understand why, like what happened with that.
Mhm.
So
it was definitely.
It was really hard.
Yeah.
To go through all of that.
I remember seeing your pictures of, all of the staples.
Yes. Oh yeah. I had like a road map of staples all over my head, and the healing, obviously it was hard to like lay on my head, and had like the worst migraine ever when I was in the hospital shortly after it was done. So yeah, after a whole month of that, just feeling like it did, all that for nothing kind of.
Right.
So,
well, then where do you go from there?
Right. It's very hard.
Well, thank you for sharing that.
Yeah,
I know
sure.
it's difficult.
For sure.
Do you currently take seizure medication?
I do. I take, let me find my notes here.
Mm-hmm.
I take 5 seizure drugs. To take naps every day, up to like a 2-hour nap. It wiped me out. And also has affected my moods. My moods can be all over the place, and I need to pace myself, because I don't have the energy like I used to. So I kind of have to choose and pick what activities I'll do for the day, and I can't do everything like most people can't. But I used to have way more energy, and it was on the go all the time. And now I have to specifically choose what's going to take up my time, because I know it will make me tired quickly.
Well, I know you talked about good brain days and bad brain days.
Good days, brain day. Yes. When I have a good brain day, like it does make me feel like I want to do everything, because I'm not promised that tomorrow is going to be another good brain day. I might be in bed for 2 days healing, and it's hard to walk, and I feel very like limp, and like my muscles aren't going to carry me. So my husband's had to carry me to the bathroom and carry me to get back into bed and get me food. And so he's kind of been my main caretaker through these years. So he's very much taken his vows seriously when you're not saying, for better or worse through sickness and health. So,
yes.
So, yes.
Let's see. What would you say the greatest challenges have been with having the seizures? I know there are many.
Yes, there's so many. The greatest challenges I would say I actually end up losing my job as an MRI tech, which I feel like as a tech is everyone's kind of fear if there is something going on in your body. And knowing that now I'm on the other side getting the MRIs done of my brain, which always was my favorite thing to scan, because I feel like the brain is just amazing, like just so complex in the way, God made us. And I just always was in awe whenever I scanned people's brains. And here I am the one laying on the table, and a tech is now scanning my brain to figure out, what's going on.
Right.
So losing my job was really hard, and something like I worked really hard for. Of course, you have to pass the state boards for that, and I'm not a good test taker, but I was able to pass the boards. I haven't been able to drive for decades, so the loss, I guess, of freedom and feeling stuck has been difficult. It's a very lonely, and it's just a very misunderstood disease. I think people think once you have a seizure, oh, it's fine, but it's like it's kind of become your life. Like we all don't know what tomorrow will bring, but it's really like living in that state of like I really don't know when the next one's going to hit, and the storm in my brain is going to go crazy, and that's been really difficult. Yeah.
Well, I could definitely understand the loss of freedom with the driving and just that isolation that you feel, and it's when you can't take care of yourself.
Right.
And I definitely have a small bit of understanding of that one.
It's tough.
What do you believe are the most important things for people to know or to understand when they have interactions with somebody who has a condition that affects their brain? Because, sometimes people don't know how to...
Yes.
Even me asking your questions, like, how do I ask questions that aren't offensive or hurtful,
I hear you.
Harm you.
For sure. I think some of the most important things I wish people would understand about epilepsy is that it is like a family disease and friend disease. I don't know how to explain it, but it affects the whole family. Of course, like I mentioned, my husband is now my caretaker. I can't drive, so he takes me to all my appointments. He's the one that does all the groceries. He does a lot more like cleaning and cooking and that kind of stuff. If I have a good brain day, then of course I'll be helping out with those kind of things. But like I said, it doesn't really, I never know. But we were unable to have children because of all the seizure meds I was on would not be good for the baby. We always wanted to have a family. So that was definitely a real loss. But we were finally able to adopt a baby girl 4 years ago. And that has been like, she's my miracle baby because like I said, I didn't think I would ever have a family. Since I get tired easily, it's hard to stay on top of cleaning dishes and cooking, like I said, since I never know when a seizure could strike. And I live in fear and I have anxiety. I've learned to be able to ask people for help. If like, just say Ryan can't take me to an appointment, to ask somebody, hey, can you take me to the grocery store? Or can you take me to this doctor's office? And asking obviously is always hard, but we can't do life alone. So I feel like it's important for me to just get over that and just ask for help.
I think it was really hard for me too, because like you, I'm sure like very independent.
Oh,
like
absolutely.
we were able to take care of ourselves, and we went where we wanted to go, and we didn't need to count on anybody else for help. And you don't realize how much you have to humble yourself to ask for that help. And that took a lot for me. Even today, I still have a really hard time
it's hard
seeking help. So I get that.
Yeah,
absolutely.
Super hard.
Yeah. Well, and you, like you said, you have an amazing little girl now.
Yes.
And it was one of the questions I had actually wanted to ask, but was a little unsure about. Like, how do you ask about what the blessings are through this? Because it's not a trial. This is your life. These are challenges that.
Yes.
But I know, like I'm sure you experienced people who have come alongside you and helped care for you and prepared meals, and so there are those ways that God has shown blessings.
Absolutely.
Your daughter is a blessing.
Yes.
But that's really a difficult one too, because not being able to have your own, I know that really weighed heavy on your heart.
Yeah, definitely. Yeah, for
Which
sure.
really is,
Jesus.
Yes.
When you look at, you guys are inspirational to me. You guys always have been. So my last question for you is, how important has your faith in Jesus been getting you guys? I mean, like you said, it's not just you, it's Ryan and it's everyone around you. How has Jesus impacted your healing and how you navigate this challenge?
Yeah. My faith in Jesus has become stronger than I ever thought it could be. I've literally had to depend on him every single day, not knowing if, like I said, about these seizures striking. And so just to have that dependence on him, that I really can't do anything apart from him. He alone is my strength, and through him I can do all things, but realizing I can't do anything without God. I really can't. He has been so faithful through all these years and has protected me. All of my seizures happen to be during my sleep hours. So actually, if you're going to have a seizure, they always say the safest place to have one is in bed, because then you have pillows and things to protect you. The worst place obviously is in the bathroom, where there's lots of appliances and hard objects and that kind of thing. And I've had seizures on the floor and different things, but I feel like towels or rugs have protected my head, and I've never had to go to the hospital for broken bones or anything like that. So I can honestly say that God has definitely protected me. Literally every single seizure I've had, Ryan has been there in bed to protect me from either falling off the bed sometimes, or like I said, just like in the bathroom, there'll be just rugs or towels right there. Just that happened that I fall into or onto. And so God is has been my protector. Things could be so much worse, and through the struggle, my compassion for others struggling with anything, whether it be, brain disease or life is just hard. So, just for the hurting, the broken, my compassion for others struggling has gone through the roof. And I cry at the drop of a hat when I hear of somebody going through something hard, because I get it. It's always in ways like others cannot, because, I've experienced it. And so it's like when they share their hearts with me, like it's like I get it.
You
Life
can
is
truly
hard.
empathize.
Absolutely. The empathy has just, and I continue to pray that this would all be for his good and his glory. It didn't take God by surprise that I would have to go through. Everybody has their thing that they go through, their struggles in life. And I do pray, that even if one life is touched by my life and they come to the Lord through my story, then it was all worth it. It really was. Think about it. What God has done for us and given his life for us. It will be worth it all. And I just hold on to hope and hold on to Jesus so much. And he really has been so faithful to me.
Our story is for his purpose.
Absolutely. Yes.
Well, thank you for meeting with me today. I know you've always been really open with your story, and I really appreciate that. And I really hope you guys are able to connect some of the things that we're learning in class and really get a sense of the compassion and the empathy that we're called to when we interact with people who have struggles in our life. Right. Thanks, class.
Thank you so much.
Good afternoon, class. I'm here to
Dementia is a progressive neurological condition that impairs cognitive functions such as memory, reasoning, and communication. It is often the result of various neurocognitive disorders, the most common being Alzheimer's disease. The next several slides will discuss the symptoms and causes of dementia, Alzheimer's disease, the brain regions affected, dementia's effects on individuals and families, in addition to management and treatment. Dementia is a term that describes a syndrome caused by various conditions that impair cognitive functions such as memory, reasoning, language, and motor skills. The symptoms include memory loss, difficulties with language, problem solving, or focus, in addition to changes in mood and behavior. The causes include Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal lobar degeneration, strokes, brain infections, vitamin deficiencies, or other neurological conditions. Alzheimer's disease is the most common cause of dementia, accounting for 60 to 80% of all cases. It presents a distinct underlying brain pathology characterized by progressive neurodegeneration in the brain due to abnormal deposits of proteins called beta amyloid plaques and tau tangles. The DSM-5 classification is major neurocognitive disorder due to Alzheimer's disease, differentiated between probable and possible based on evidence from genetic testing or biomarkers. Alzheimer's disease is progressive and irreversible, with the early stage beginning with subtle symptoms, the middle stage progressing into worse symptoms, the late stage going into severe cognitive decline, and the end stage often leading to death. Alzheimer's disease progressively affects multiple regions of the brain displaying characteristic symptoms. The damage begins in specific areas and spreads over time as the disease advances. The early stage affects the hippocampus, temporal lobes, and basal forebrain, disrupting memory and its formation, language, and auditory information processing, leading to short-term memory loss, difficulty understanding words, trouble retrieving memories, and cognitive decline. The middle stage affects the parietal lobes, amygdala, cerebral cortex, disrupting spatial awareness, high-level cognition, and emotions, leading to disorientation, trouble with spatial tasks, anxiety, mood swings, agitation, and severe cognitive and functional impairment. The late stage affects the frontal lobes, disrupting executive function and behavior, leading to poor judgment and changes in personality. In rare cases, the occipital lobes are affected, causing visual impairment. The end stage affects nearly the entire brain, including the brainstem, interfering with breathing and heart rate, often leading to death. Individuals suffering with dementia experience profound cognitive, emotional, and physical changes. Cognitive decline is inevitable, resulting in progressive loss of memory, attention, problem-solving skills, and reasoning abilities, making it difficult to remember recent events, recognize loved ones, or perform everyday tasks. Behavioral and psychological changes cause emotional challenges as individuals may experience personality shifts, depression, anxiety, agitation, and paranoia, in addition to hallucinations and repetitive behaviors such as mumbling and wandering. Physical changes occur through motor skill challenges, malnutrition, and a vulnerability to infections as the disease progresses. Individuals often lose their independence, requiring assistance with basic activities such as bathing, eating, and dressing, leading to significant dependency on caregivers. Dementia also affects family members emotionally as well as financially and socially, especially those serving as caregivers. Families often grieve the progressive decline of their loved one's cognitive and functional abilities. Additionally, caregivers frequently report issues with stress, depression, and anxiety, especially during the middle and late stages of dementia. Financial burdens become heavy as dementia care can be costly, including medical bills, in-home care, and long-term care facilities. Families often bear much of this load, leading to economic strain. Social isolation does not only affect those suffering dementia, but families and caregivers as well. Oftentimes, caregivers feel isolated due to the demands of caregiving and the social stigma associated with dementia. They may also feel burned out from providing exhaustive care, often neglecting their own health in the process, especially in the absence of external support. Dementia management focuses on addressing cognitive decline, behavioral symptoms, and caregiver support. There are countless research publications on pharmacological treatments, non-pharmacological interventions, and caregiver strategies to improve outcomes for patients and families. Pharmacological management can include cognitive enhancers and neuroprotective agents such as cholinesterase inhibitors and memantine, which prevent the breakdown of the neurotransmitter acetylcholine to improve memory and cognitive function and regulate glutamate activity in the brain to protect neurons against overstimulation. Additional medications such as antidepressants and antipsychotics can address depression and anxiety, plus severe agitation or psychosis. However, they should be prescribed with caution because of the risk of side effects such as stroke or increased mortality. Non-pharmacological intervention options for treating dementia include cognitive stimulation therapy, or CST, along with behavioral and psychological strategies. CST is a structured program involving group-based activities to stimulate memory, problem-solving, and language. It directly engages patients in social and mental exercises, aiming to enhance their cognitive performance to improve cognitive function and their quality of life. Behavioral and psychological strategies that help manage the symptoms of dementia include music and art therapy, reminiscence therapy, and exercise programs. These methods may reduce agitation, depression, and improve mood, stimulating emotional memory and engagement to enhance overall physical health. Environmental adaptations, such as living space and diet adjustments that include labels on drawers, removing hazards, and a diet that is rich in antioxidants, omega-3 fatty acids, and vitamins, may slow cognitive decline and promote safe independence. We must remember that dementia is taxing on family members and caregivers. Therefore, support and education is an essential component to managing and treating dementia. Psychoeducation can address dementia progression, coping strategies, and caregiving techniques, which can reduce caregiver stress and improve quality of care. Additionally, respite care can offer temporary relief services for caregivers, providing opportunities for rest and maintaining their well-being, which indirectly benefits patients. In summary, dementia is complex, progressive, and incurable, profoundly impacting individuals, families, and caregivers. Effective management combines treatments and interventions to alleviate symptoms and enhance the quality of life for those affected. This approach balances the needs of patients with the well-being of caregivers, emphasizing the importance of education, support, and continued research to improve care and outcomes.